A continuar con la segunda presentación de esta sección de endocrinología, y para eso invitamos a mi buen amigo Anthony Heaney. Anthony es nacido en Irlanda. De hecho, él hizo la escuela de medicina en Queen's University en Belfast, y su entrenamiento de posgrado tanto en medicina interna como en endocrinología y metabolismo, y el doctorado en ciencias en la misma universidad, trabajando generalmente en el Royal Victoria Hospital y en el Mater Informarum, que es un hospital ahí en Belfast. Después de esto, trabajó un tiempo en Manchester como investigador y clínico, y se hizo acreedor a una beca Fulbright. En 1997 se vino a América, buscando particularmente a Shlomo Melmed en Cedars-Sinai, en Los Ángeles, donde les puedo decir que el doctor Heaney hizo descubrimientos importantísimos en el campo de la oncogénesis hipofisaria. Posteriormente pues decidió independizarse y se fue a UCLA, donde actualmente es profesor de medicina y neurocirugía en esta escuela de medicina David Geffen, que es de la Universidad de California en Los Ángeles. Anthony es muy conocido por su experiencia en tumores hipofisarios funcionantes y no funcionantes, pero particularmente por sus contribuciones hacia la oncogénesis hipofisaria. Es sin duda una de las personas que más saben en el mundo de cáncer de hipófisis, que es una de las cosas más raras que existen. Y bueno, él es un buen amigo, tenemos muchos años de conocernos, de interactuar, y sin más, él fue coeditor de Journal of Clinical Endocrinology and Metabolism, ha servido en muchos comités, tanto de la Endocrine Society, fue presidente de la Pituitary Society. Vamos, tiene una trayectoria académica de mucho peso, y pues es el clásico physician scientist que tiene un laboratorio, pero también ve pacientes. Entonces, como que este paradigma cada vez se hace más constante. Ha publicado una cantidad brutal de artículos sobre temas relacionados a la neuroendocrinología, y es una persona muy generosa cuando se trata de compartir conocimientos. Pues, Anthony.
Moses? Oh, perfect. Thank you. So thank you so much, Moses. I hope you will understand my English. And my Spanish is not very good, and I'm embarrassed to say that, given I come from Southern California. I met Moses, probably we were thinking about this yesterday. I had the most wonderful afternoon with his research team across the street. We talked about science and medicine. It was really a wonderful experience, and I think we met probably 15, maybe almost 20 years ago, and we've shared a love of pituitary tumor research across that time. And I share with Moses that I think pituitary tumors can teach us a lot about oncology in general, because one of the things that has perplexed us all for many years is why these tumors are so common and yet rarely metastasize. And even some of their close cousins that we just heard about, these GEP-NET pancreatic NET tumors, typically metastasize 70% of the time. Pituitary tumors, fortunately for us, unfortunately for patients, metastasize probably about 2.2% of the time. And yet they are very commonly invasive, very, very common tumors. So I'm hoping to share with you some insights into that as we talk today. And it's a real privilege to be here in this just amazing auditorium. And I'm so glad that lunch did not put you all to sleep, and that you were able to summon the energy to come for this session. So I'm going to jump right in. So the objectives, I want to try and talk a little bit about terms, and we sort of loosely use this term aggressive in pituitary tumors. But I have argued with colleagues for many years that I don't think we really do have a good definition of this term, and it means different things to different people. It's one of those things, you may have heard, I come from Ireland originally, and we used to say, or my mom used to say, all crows are black birds, but not all blackbirds are crows. And so we really struggle to define this entity, an aggressive pituitary tumor, and yet it's important because it's one of the transitions that we see in these tumors to carcinoma. So we'll talk about really, can we define this entity? And I don't think we can at the present time. What would be really helpful would be if we could prospectively identify these tumors, because then we could select our patients who really need to be watched very carefully. And I don't think we have the tools yet to do that. I'm going to illustrate that with some cases. And I took part in the original European Society of Endocrinology guidelines in this area, and we've just done an updated version which will be published in the next 3 to 6 months. And I'll talk about some of the conversations we had as part of developing that guideline. And then I'll finish by just talking a little bit about how we manage these tumors, because they really can be very challenging. So as I've said, pituitary tumors are very common. If you look at autopsies, you do MRIs in an unselected series of even normal subjects who wander into the ER after a bicycle accident or a skiing accident, you will find pituitary adenomas in up to 10 to 15% of people. Now, most of these are unimportant. They don't come to attention during the patient's life. And it's really these other tumors that are relevant clinically that we talk about. And the incidence of these, or prevalence rather, is about 80 to 100 cases per 100,000, with an incidence annually of about 4 per 100,000. So they're still pretty common. They're actually the third commonest brain tumor after gliomas, meningiomas, and then we have pituitary adenomas, which technically are outside the brain because the pituitary hangs outside the brain, but they're included in brain tumors. The behavior of these tumors is extremely variable. A lot of them remain stable, some for the entirety of the patient's life, and they don't need any treatment whatsoever. Others may grow, but even the ones that grow generally grow very slowly. So we really are going to be talking today about the rarest of the rare. But in some cases, we see rapid tumor growth, and that leads to a lot of challenges for the patient and for the physicians and other healthcare providers that are trying to help the patient. If we look at postoperative patients, and you could argue that that group self-selects themselves because they are perhaps more proliferative in nature, about 30% of these tumors will regrow over time. And regrowth has been seen even 30 years after the initial surgery in the patient. And we really don't understand why these tumors sometimes go to sleep for a lot of years and then start to grow. We suspect it's environmental epigenetic changes locally in the tumor. Somatic mutations are very rarely a cause of pituitary tumors, and even more so rarely germline mutations. So a lot of this seems to be epigenetic in nature. This is taken from a review that Dongyong Zhang and I wrote a number of years ago, really just showing how we think about pituitary tumors. On the far left, we have an MRI of a normal patient and a schematic of the normal pituitary. Adjacent to that, we see a small adenoma tucked down on the right side of the pituitary gland, but confined to the cella itself. And then if you look at the third panel from left, you'll see we now have this invasive tumor, which has invaded into the adjacent structures to the pituitary, the cavernous sinus. It's on the far side of the carotid artery that you can see just here. And so this tumor is compressing cranial nerves on that side, and so on. And then on this farthest image, we have actually a metastasis down near the brainstem. So this patient, by definition, has pituitary cancer. And we believe that pituitary cancers at one time were these invasive tumors, and prior to that were tumors confined to the cella. But we don't understand why this transition occurs. And you'll see that actually on this panel, this has been called an aggressive tumor. But I would argue that we don't know that this is an aggressive tumor. All we can say from this MRI is this is clearly an invasive tumor. But it may not be aggressive, and this is where we come down to terms. So I don't know if you know this, but I know Moses loves history. He was ridiculing us all yesterday because we didn't know the origin of, or the family history of chimera. But anyway, the word aggression supposedly was first used, the word, in 1611 in describing the St. Bartholomew's Day massacre, which occurred on August 24th in 1572. And as you know, we humans have loved religious wars throughout history. I understand there was a bit of a war in the White House a few hours ago between our president and another president of another country. But the story goes that Catherine de' Medici, who was the mother of Charles IX, King of France, was concerned that Admiral de Coligny was bringing him into a war with Spain. So she arranged an assassination attempt on the admiral, as you did in those days. It was unsuccessful, and Charles then tried to placate the Huguenots at the time in ordering an investigation of what had happened. Catherine persuaded her son that the Huguenots were on the point of rebellion, and conveniently for them, they were actually all in Paris for the weekend because their leader, Henry de Navarre, was marrying no less than Catherine's sister, Margaret. And so they decided to take the opportunity to wreak havoc on the Huguenots. And Admiral de Coligny was the first literally out the window. He happened to be 3 stories up and was killed immediately at dawn on August 24th. And thereafter, there was a bloody religious massacre throughout France where some 70,000 Huguenots were killed by Catholics in France. So that's the origin of the word aggression. So with that backdrop, and it's sort of memorized in this painting by Francois Dubois. So among pituitary tumors that require treatment, these are the ones that I mentioned earlier that come to attention of physicians. Most of these tumors we can easily control with standard therapies. Sometimes that's medicine. For example, lactotroph tumors, we use D2 agonists, which are really excellent targeted therapies for lactotroph tumors. Sometimes we need surgery. Sometimes we need combinations of medicine and surgery. And occasionally we need radiation for those bad actor pituitary tumors that continue to grow. And these treatments are highly effective in the vast majority of pituitary tumors. Local response to radiation, for example, is somewhere between 90 and 100%. But there's a small subset of pituitary tumors that are characterized by multiple recurrences despite surgery, multiple surgeries, medical therapies, radiation, anything that we can throw at them. And this makes up about between 1 and 5% of pituitary tumors, depending on how you define these tumors. So one of the tasks of the recent guideline that I took part in was to try and understand what is the normal growth rate of a pituitary tumor. And so 2 groups of patients were looked at. And I should say the data in this area is very poor. But looking at patients who had not yet had treatment, these were treatment naive and followed between 3 and 7 years. And the tumor volume doubling time was estimated to be about 3 years. There was a separate group studied who had undergone surgery. And again, you might expect that those patients had self-selected themselves because they had needed surgery, that they might have more rapidly proliferating tumors. But it turns out that the tumor volume doubling time was about the same. It was about 3 years. So one of the consensus that is going to emerge from this guideline is that if we see a pituitary tumor that progresses faster than over 6 months, that is unusual for a pituitary tumor, and that is a warning sign that this tumor may be more proliferative. Not all aggressive pituitary tumors grow rapidly from their initial presentation, and the time interval from the primary diagnosis to demonstrating their aggressive behavior has varied from months to even more than 10 years. And there may actually be extended periods when these tumors have a period of clinical quiescence, they don't grow, followed by rapid tumor growth, invasion, and or metastases. And we don't understand at a biological level how this is enacted. The aggressive tumors sometimes, but not always, have certain features, certain histopathological abnormalities. They have elevated Ki-67, which we saw a moment ago. It's a proliferative marker that marks cells in G2M and S1 phase of proliferation. They may have increased mitosis. And if you look at that group of patients with these features, it makes up about 10% of tumors in surgical series, and yet only 5%, as I said earlier, will become aggressive tumors. So how do we pick up these tumors if it's so difficult? Well, there are a few red flags, and I'll illustrate this with cases in a moment. In the setting of prolactinomas, sometimes we see resistance to the medical treatment that we use, so-called D2 agonist resistance. A change in the tumor secretotype is a warning sign, and what I mean by that is you have a tumor that is not making hormones for years and years and years, and all of a sudden it starts to make hormones. Or the reverse, a tumor that is making hormones and then stops making hormones. Those are indicators that some type of transdifferentiation has occurred in that tumor. There are some subtypes of corticotroph tumors that are particularly challenging and with a high risk of recurrence and progression. This includes the Crook cell tumor, which is a type of keratin that we see sometimes in these corticotroph tumors, and then the so-called silent corticotroph tumor, which do not secrete functional ACDH. And these tumors are missing a whole array of the transcriptional requirements to synthesize, process, and store hormones. We recently looked at a large group of these tumors using single-cell RNA sequencing, and they're a very different animal to the tumor that causes hypercortisolism, which is more what we think of when we think of corticotroph tumors. Bony invasion is another feature. The clivus in particular, I think, is an ominous sign in a patient. If the patient has a history of multiple surgeries, that would usually indicate that you're dealing with a problematic tumor. But a caveat here is it depends on the surgeon. And certainly in the US, and I hope Mexico is in a better situation than we are, but we have a lot of surgeons, a lot of neurosurgeons who do 1 or 2 pituitary surgeries a year. And suffice to say, if you're doing 1 or 2 of any procedure, you're not going to be that skilled at it, and that's a major issue. So it depends on the surgery and what surgeon the patient had surgery with. Growth despite radiation is a worrisome sign, but again, we have to think about the dosing of radiation, the field of radiation, because if you have growth outside of the field of radiation, that does not necessarily mean that you're dealing with an aggressive tumor. The Ki-67 is helpful, but I would argue it's not that useful as a standalone marker. And these tumors are more common in men. These carcinomas and aggressive tumors are more common in men. So I'm going to play a little game here, have a little fun. I like to tease the pathologists with this. So we're looking at this image, and you might think this looks like some type of villus structure, perhaps in the gut. And this is really to, I think, give an example of the very minimalist lens that we all bring to our patient care. And we as endocrinologists, or I as an endocrinologist, and someone as a radiologist, or someone as a pathologist, you really only have one sort of aspect looking at things. If we look at a higher power, again, you might think this is some type of villus structure in the small bowel, but this is actually a passion fruit, and it's not actually a pathological specimen at all. Really to make the point that we can all be misled by some of the things and the bias that we bring to many of the assessments that we make. This is the original paper on Ki-67 by Kamal Tapar, who at that time was working with Kalman Kovacs in Toronto. And at the bottom here, we see pituitary carcinomas, which you see some carcinomas have an unmeasurable Ki-67. Others have very elevated percentage of cells positive for Ki-67, up to 20+%. And what we see here is that Ki-67 as a marker is quite good to distinguish pituitary carcinomas and invasive pituitary adenomas from non-invasive tumors and normal pituitary gland, but there is significant overlap between the carcinomas and the invasive pituitary tumors. And it's really not, as I said earlier, as a standalone marker, very helpful. That said, when we look at the aggressive pituitary tumors and the pituitary carcinomas, they do have, generally, not always, 31% for aggressive, 55% for the carcinomas, higher mitotic counts, elevated Ki-67, greater than 3% of the cells. And certainly if you're looking at a Ki-67 of greater than 10%, that is very unusual in a pituitary tumor and very unusual in many types of neuroendocrine tumor. It's important in the other neuroendocrine tumors we just heard about as well as a cutoff. You may be thinking, well, why are we looking at some of these old markers and why haven't we advanced with molecular studies? There is some movement in that regard, but none of these are yet ready for prime time, and they do not influence clinical care at the present time. But for example, P53 and ATRX mutations have been found in the more aggressive, recurrent, problematic corticotroph tumors, and this other gene called SF3B1 has been shown in lactotroph tumors to have a very high association with metastasis in up to 50% of patients. And the good thing is that these abnormalities are found early in the patient's history. So you will find these mutations in the first biopsy from a patient. A lot of mutations, as we know, can sometimes occur as a consequence of treatments such as radiation and so on, and the tumors accumulate these mutations over time. But these mutations appear to be occurring early in the course of the patient's history with their pituitary tumor. And so they may help us identify patients that need more careful care. So a few caveats before I show you some cases. A tumor that progresses following a suboptimal surgery may not be aggressive. That comes back to the quality of the surgery. And a tumor that is growing outside of the field that was previously irradiated may not be an aggressive tumor. And that may seem like a very obvious thing to say, but it can be very difficult when you meet these patients and they had radiation 5 years ago, 10 years ago, to figure out what part of their tumor was irradiated. That can be a real challenge to get that information at all, even with electronic records. Various efforts have been made to come up with a classification system on this. I think the best has come out of Gérald Ravereau's group in Lyon, where they used a combination of radiological invasion, the so-called NOSP criteria, which essentially measures invasion into the cavernous sinus, as we saw in one of the earlier slides I showed, and then that's combined with some of the proliferative markers that I've mentioned, Ki67, et cetera, and the grade 2B categorization in that classification has a 3.5 and 12-fold higher risk of recurrence at 3 and 8 years respectively after surgery. So here's a case, and I show you this case because when I show you the scans in a moment, you might intuitively say, you know, that is a really nasty tumor. So this is to make the point that invasiveness alone or a large tumor is not always synonymous with aggressiveness. So this is a 25-year-old patient of mine, a male. He reports worsening vision and loss of balance. Now, loss of balance is very uncommon with pituitary tumors, but you'll see why in a moment. He has remarkably says he has normal energy and libido, and yet his total testosterone is really low at 41. His prolactin, as you can see, is very elevated. So this is his MRI, and you'll see he's got this really ugly-looking tumor that is occupying the entirety of the sphenoid sinus, elevating upwards. We can't really even see his chiasm or pituitary, and it's invading backwards, and this nodule here is pressing on his brainstem. That's why he was reporting balance issues. And you can see here on the coronal image, there is a lot of tumor bulk. So this is clearly a very invasive, a very large tumor. And many people would look at this and say, well, it has to be aggressive. But we started him on cabergoline, which is a D2 agonist, and within 9 days, his vision got better. We increased that stepwise to 4 tablets, 2 milligrams twice a week, so he was on 4 milligrams per week, which is a generous but not massive dose of cabergoline. And this is his scan 2 years later. Now, he still has a lot of tumor. We can see that he has, but now we can see his optic chiasm clearly. We can see the pituitary stalk. The brainstem is completely clear of tumor, and his tumor volume has shrunk by about 70% with D2 agonist therapy alone. So this tumor, although very big, very invasive, responded beautifully to the medication, a simple medication that you take twice a week. So that's really to try to show you there is a difference between invasion and aggression, and not all big invasive tumors are aggressive. Now here is a different story, and the kind of patient that I think we all see a lot, and this is a kind of a story that describes the aggressive tumor. So this is another 25-year-old male, headaches, blurry vision, fatigue, again, prolactin very elevated. He had a craniotomy at an outside hospital, complicated by a right fourth nerve palsy. Post-operatively, his prolactin is better. It's now 3,500 instead of 10, and he's commenced on cabergoline again, which is the standard treatment that we would use for these patients. And initially, he has quite a nice response, as you see here. So that looks promising. It looks like his prolactin is on the way to normalizing, but then he has this little bump about 6 months into treatment. So his cabergoline is increased. This is his MRI at this time. Again, you can see the large amount of tumor here on the sagittal. The carotid artery is beautifully silhouetted in the midst of the tumor. And it's quite remarkable that these tumors, they do not invade arteries and vessels. They don't even compress vessels, even though they can be very large, which again sets them apart from the typical carcinoma. So his cabergoline is increased to 3 milligrams a week, doesn't really work, so he has a second craniotomy, and temporarily his prolactin falls. But you can see again then it starts to gradually creep up. His tumor on his MRI scan has also grown. Some areas of infarction here. We see this lucency at the back. His cabergoline is now up to 7 milligrams a week, and he decides to take part in a clinical trial at the time of the EGFR antagonist lapatinib, which, as you can see, was not really successful. So this, in my mind, is clearly a young man that has a really problematic tumor that is starting to blow through pretty much everything we've thrown at him so far. So this is now a couple of years later. He has his third surgery, a double surgery, a transnasal transfenoidal approach at the same time as another craniotomy. Again, he has a response in the short term to that, but again, this tumor starts to try and move and grow back, and his prolactin comes up, and he then has proton beam therapy at that point. So this is his scan in 2018, and this is his most, well, not his most recent, but the one that I'm showing you from 2019, at which time now his tumor, still a lot of tumor, but his tumor has stopped growing. His prolactin at that time was 319. I still see this young man, and he remains on cabergoline, 7 milligrams a week, and his tumor has not grown since that time. So sometimes, despite these tumors being very aggressive and hard to handle, if we treat them with this multimodal approach, with a combination of surgery, medicine, radiation, we can eventually get them under control. Now to talk about carcinomas. Now here we have a definition, and really the definition is that you have pituitary tumor that is outside of the sella. So it's either in the craniospinal space, meninges, spinal cord, or it is further afield, hematogenous spread, or perhaps lymphatic spread. This is the rarest of the rare. This is only 0.2% of pituitary tumors, but I would see 5 to 6 of these in any given year because we get a lot of these patients. The prognosis is very poor with a 1-year survival or thereabouts. And interestingly, both the aggressive pituitary tumors and pituitary carcinomas are more common in corticotroph tumors and lactotroph tumors, and yet those tumors are not the most common tumors that are operated on surgically. So there clearly is something about the corticotroph pituitary tumor and the lactotroph pituitary tumor which is different to the other tumors. Even the tumor that makes growth hormone and produces excess IGF-1, it's a very rare cause of pituitary cancer. And so that is a little counterintuitive. So the corticotroph, lactotroph tumors are most commonly the corticotroph cancers, the pituitary cancers that we see. Most commonly in the CNS, 50%, and then sometimes we see lymph node involvement and even spread to the liver and bone. And the metastases don't always occur quickly. There have been cases within 6 years after presentation, cases even 36 years after presentation. And typically it's about 3 to 4 years after the tumor reveals itself as an aggressive pituitary tumor. And part of the reason I included aggressive pituitary tumors here is because really this is a continuum of this tumor phenotype. And if we had a way of better characterizing and identifying the aggressive pituitary tumors, we would get the early jump on the patient that was going to have ultimately a pituitary carcinoma. So here's another case, and I've called this "Things Are Not Always What They Seem," and you'll hopefully understand why in a few slides. So this is a 43-year-old male. He's got a 10-year history of type 2 diabetes, goes to his primary care physician with 1-week history of blurry vision and right eyelid droop. And his outside MRI, which I'll show you here, showed this clival mass. This is without and with contrast. So this entire area here, sort of a wedge shape, is his tumor. So his clivus essentially is entirely obliterated by this tumor. And based on that appearance, it was presumed to be a chordoma, which is one of the other tumors that we sometimes see in this space. So these are the coronal images here. You can see certainly a lot of tumor in the sellar space as well. Here's the optic chiasm. This is the pituitary stalk. So his normal pituitary is kind of pushed to the left and pushed backwards by this tumor. So as part of the pre-surgical workup, he gets a medical evaluation, and obviously this patient is clearly cushingoid. He's got all the features. We saw some of these earlier in some very beautiful slides, but this patient has got the striae, the bruising. He's got an active staph infection on his leg. He's got the rounded face, etc. And biochemically, as shown here at the bottom in black, very elevated urinary free cortisol, elevated plasma ACDH. So this was not actually a chordoma. It was actually a corticotroph tumor. So the tumor has been resected, and you can see here this is pre-op. Post-op, all this tumor is gone. You can actually see now his normal pituitary, and this may, in hindsight, have been an ectopic pituitary tumor in the clivus, but he still has some residual disease here. You can see that sort of moth-eaten appearance of the clivus. So he had fractionated radiation to that residual tumor. We then tried to treat him medically for his hypercortisolism and followed him serially with images. And you can see here, I put a series of his coronal MRIs from 2010, 11, 13, and there really was fairly static residual, very small residual tumor here on the left side of the sella at that time, but his plasma ACDH was creeping up, and we couldn't really understand why, given that he did not seem to have progression in the primary site of his disease. So on one of his scans, a CT scan for neck discomfort, a enlarged lymph node was noted in his neck. And in hindsight, looking back to 2013, even 2011, this lymph node was probably already involved. And this is one of the reasons, the guidelines are advising us that if we see discordance in the clinical picture or the biochemical picture of the patient, you really want to consider metastatic disease and evaluate the patient with perhaps CT PET imaging or SSTR PET NetSpot testing, which sometimes could be very informative in these patients. So we struggled to control this patient biochemically. We have much better drugs in this space than we had even 5 years ago, but he was really having a miserable life with hypercortisolism despite all the typical drugs that we had at the time, ketoconazole, meteropone. We tried everything with him and got some control of his cortisol, but not totally. So he decided that he wanted to be done with that, and he wanted to have a bilateral adrenalectomy, which we do occasionally in these patients. And you can see him here on the right, 5 years after his initial presentation. He actually felt great. He's more pigmented because of the elevated ACDH, but he has lost a lot of weight. His diabetes is better, his hypertension is better. So he had a lot of good years, but what I'm going to show you next was not entirely good. So these are the series, again, of coronal images. This is his presentation in 2010, some residual disease here, fairly stable 2011, perhaps a little growth by 2013, here in 2015, roughly about the same. This is where he has his bilateral adrenalectomy in April of 15. And by October 15, we see this residual tumor has already started to blossom. It started to grow. And by December 15, only 8 months after the adrenalectomy, he now has major growth of this residual mass. And this is a major problem with these tumors because the cortisol, the excess cortisol, has a negative feedback and tumor suppressive effect on the primary tumor. And when we fix that, which is obviously what we want to do because the cortisol is causing a lot of the morbidity, well, most of the morbidity and mortality in these patients, we actually encourage the tumor to grow. And we're seeing this now with the medical therapies that we have. We now have some really efficacious medical therapies such as osilodrostat, which is a very potent inhibitor of cortisol synthesis, but we are seeing tumor growth, pituitary corticotroph tumor growth in patients treated with osilodrostat, because essentially what we're causing is a medical adrenalectomy with these medications. They're so good. So this patient, you can see his ACDH is 2820. At that point, we give him temozolomide 8 cycles, which is an alkylating agent that we used first for a pituitary lactotroph carcinoma back in 2006. It's now become the standard of care. Never been trialed, never will be trialed, but it's become the official or unofficial standard of care for pituitary carcinomas. But you can see that despite that, in April of 2017, 7 years after his initial presentation, he now has liver metastases. And we biopsied these, confirmed they were ACDH-producing corticotroph carcinoma, and we give him nivolumab, which was being used in so many, and still is being used, so many other cancers, but unfortunately that was not effective, and he died in June 17. So that's an example of how these pituitary carcinomas typically unfold. So how do we treat these tumors? And you've seen in the cases I've presented, it's really a combination of surgery and sometimes multiple surgeries. Surgery is very effective for rapid relief of symptoms that the patient may have. These patients will show up in the ER with loss of vision, severe headache, and even though you know that surgically you cannot cure this patient, you can debulk that tumor and give them relief of those symptoms. I have a 35-year-old female patient right now who is undoubtedly going to die in the next 3 to 4 months with her lactotroph cancer because she has failed everything that we have done. But she gets very severe headache, and from time to time, our surgeons will endoscopically debulk her tumor and buy her another 9 to 12 months of life. Radiotherapy is another tool that we use frequently in these tumors. Very good control, but no randomized studies of radiation. It's really remarkable that there's so many things that we do in medicine and they have never been trialed. I'm not sure if you're aware, but things like chemoembolization, bland embolization versus chemoembolization, never been trialed and compared. We just do these things. The effect of radiation on hormone control is less oppressive. Only suppresses prolactin in about 50% of lactotroph tumors, and that may actually take 5 years. There seem to be no differences between external beam radiation, LINAC, gamma knife, proton beam. You can use whatever radiation modality you want. Proton beam has the advantage that its fall off of target is much shorter than LINAC and gamma knife, so if you're trying to radiate structures near radiosensitive tissues, the proton beam can have some advantage, but in terms of risk-benefit, they're pretty much equivalent. Hypopituitarism, we see that in about 40% of patients when we radiate the pituitary, but clearly if you're dealing with an aggressive tumor or a cancer, some of the ones we've seen, the risk-benefit shifts for those patients, and you're willing to sacrifice the pituitary gland in order to maintain survival of the patient. In the US, we don't re-irradiate typically until after 9 years, but I know some colleagues in Europe are radiating sooner than that. There are major issues with cerebral necrosis, which I've seen several times with repeated radiation, second tumors such as meningioma, but particularly radiation-induced necrosis in the temporal lobes that you see in radiating the pituitary. I mentioned temozolomide, and I say we used it first in 2006. There have now been several thousand people treated around the world with the drug. This is just one sort of meta-analysis of 439 patients treated with temozolomide. And you can see that the response rate, this is complete or partial radiologic response based on RECIST criteria, is almost 40%. It's certainly not 100%. And many of these responses are short-term. And when I say short-term, it's 4 to 5 years, but it's still 4 to 5 years in a patient that would otherwise have died perhaps within a year. You do see tumor size reduction, slightly better in the lactotroph tumors. Complete responses are rare, but have been seen, about 5%. And you see that in carcinomas as well as aggressive tumors, which is really gratifying to see all these tumors in multiple sites just melt away. And the 5-year survival is about almost 60%. And you can either treat with the temozolomide alone, which is an alkylating agent. It's an orally administered alkylating agent, 4 days out of 28 typically, or you can give it in combination with radiation, the so-called STIP protocol. And in terms of duration of treatment, I know that my oncologists, neuro-oncologists in UCLA are used to treating gliomas with this drug. So they typically want to give 10 to 12 cycles and then stop. There is some evidence that it's better to actually continue the drug if the patient responds. And people have tried to be creative and reduce the dose of the drug to half the usual dose and so on, because there are concerns with long-term use of an alkylating agent that you can cause a myelodysplastic syndrome. So a lot of oncologists, I'm not sure what your experience has been, but they do not want to go beyond a year with this drug. Some evidence that low MGMT expression may be associated with a better response, but given we don't have a lot of other options for these patients, most physicians managing these patients would treat them with temozolomide and see if they respond, because we don't really have alternatives. A lot of excitement about immune checkpoint inhibitors certainly transformed the management of many, many cancers. It's really been amazing. And clearly there was interest in this group of drugs in pituitary tumors as well. Unfortunately, not very impressive. 3 studies so far totaling 25 patients. Some patients were given the checkpoint inhibitor as monotherapy, others in combination with other drugs, treated up to just over a year. Some partial responses, stable disease reported, no complete responses seen, and really almost 65% of patients exhibited progression in their disease despite the immune checkpoint inhibitors. So I don't think this is going to be the answer for this group of tumors. So what do we do for these patients when all the usual things fail, including temozolomide? And really, at this point, we're very much off the page. Probably one of the most interesting drugs has been Avastin, or bevacizumab, which is the monoclonal antibody to vascular endothelial growth factor. And there are about 11 patients treated so far. Again, no complete responses, a couple of partial responses or stable disease between 7 and 16 months. But again, this does not seem to be the solution for these patients. Other things have been tried. We had a patient some years ago that responded to the mTOR inhibitor, everolimus, and Andy Lin, Sloan Kettering, has another 2 or 3 patients that have also responded. But really, these patients, there's not much to offer them, perhaps a clinical trial of some kind. The other thing that comes up sometimes is trying to use some type of radionuclide. And I mentioned that some of these tumors do have the somatostatin receptor, and you can pick them up on a dotatate PET scan, or NET spot as it's called. And there is a Thera part of that diagnostic, a so-called theranostic, using lutetium-177, which is approved for in the US for the treatment of carcinoid and GEP-NET tumors. So you can use that as a possibility, and there have been some patients treated, 12 patients thus far, a mixture of prolactinomas, non-functioning tumors, etc. 6 of 12 have responded with stable disease, but almost as many non-responders. And this is just a small review that Stefan Pettersson and I wrote a few years ago on this subject. So again, this may be helpful for individual patients, but certainly not going to be the solution for the majority of patients. So just to summarize, these tumors, again, I want to emphasize, are very unusual, very rare. Thank goodness the vast, vast majority of pituitary tumors that we all see and manage are completely benign, respond nicely to the treatments we use, whether it's medical therapy with D2 agonists for lactotroph tumors and somatostatin receptor ligands for somatotroph tumors, surgery, occasionally radiation. But these aggressive pituitary tumors are important because they can progress to pituitary carcinoma. And as I mentioned earlier, for reasons we do not understand, they are more commonly seen in the corticotroph and lactotroph lineage. And I think I've shown you that it's very difficult to call out these tumors until really they have demonstrated their behavior over many, many years. So you can look in hindsight and say, yes, that was an aggressive tumor because it did this and this and this and this and this. But what we don't have currently, at least in my opinion, is something that we can analyze in the initial tumor and say, this tumor is going to be a problem. We really need to, treat this patient, aggressively, and we need to watch them really, really closely. We do not have those types of tools. Temodar, as I mentioned right now, is the best option we have, either alone or in combination with capecitabine. Those two have never actually been compared, so there's no evidence in pituitary tumors that using Temodar in combination with capecitabine is any better than Temodar alone, but that's an option you can consider. And clearly, in my opinion at least, there's an unmet need for other treatments for this rare subgroup of patients. I'm really just a spokesperson for a large team of people that manage these tumors in our medical center. Here on my right is one of our sort of lead pituitary surgeon, Marvin Bergschneider. And here amongst this group, we have histopathologists, we have radiation oncologists, and so on. And our head and neck surgeons, Marlene Wong and Jeff Su. A lot of the surgeries around the world now are done as a sort of a combo team with a head and neck surgeon and a neurosurgeon working endoscopically through the nose. It's really a very different approach to what was done even 15, 20 years ago, and gives the opportunity for much, much better resections. But even in these aggressive tumors, it can be a real challenge to remove all of these tumors. So I'm going to stop there and just say thank you, and happy to take any questions that you might have.